Welcome to the NWATC Project ECHO. I'm Kent Unruh. I'd like to turn it over to Kristen Ramers to introduce our guest.
All right. Hello, everyone. It's my pleasure to introduce Dr. Dana Reddy. Dr. Dana Reddy, you've heard her speak here before. She's a soon-to-be associate professor of infectious diseases at the University of Washington and is actually on the advisory committee
on the OI prevention guidelines.
That's right.
And the IDSA immunocompromised host vaccination.
Great.
guidelines.
So on two committees that are involved in immunization, so she really has kind of the inside information. Unfortunately, she can't share all of it because some of it's embargoed. But she can kind of give us her thoughts on immunizations in the HIV-infected patient. So turn it away.
And if you ask me questions, I'll answer them, of course. So this can be interactive. So yeah, vaccines for the HIV-infected patient. I usually give this in the context of a primary care talk, but since we have shortened topics here, I want to focus on just the vaccines that we deal with most often in our primary care practices when it involves patients infected with HIV. So some sort of overview of the talk. What I wanted to do was talk about some general principles of immunization and then review some of the recommended vaccines in adults as it pertains to HIV, and then sort of just go through quickly which ones are not recommended and why, and then some special considerations, in particular the issue of non-response and revaccination. So in terms of general principles, obviously, as it is in the general population, the goal of immunizations is to prevent infection. In HIV, though, one thing it's a little bit different is the timing. Most of the time when we talk about immunizations, we're talking about an age group, particularly because it affects certain age groups more. For instance, when we talk about meningococcal vaccine, we want to immunize children before they are exposed to it in the ages that they would be most likely to be exposed to meningococcal disease. In HIV infection, another timing consideration to think about is when during infection and when during sort of the treatment course of HIV should we immunize. So we know that people with HIV have decreased immunologic response to most vaccines. And some of those factors that contribute to poor response are low CD4 count and then also lack of virologic suppression. So the timing comes up, well, should we vaccinate early or later when they're in care? For instance, early, if they come in with low CD4 counts, should we go ahead and vaccinate or wait till they're on antiretroviral therapy and their CD4 counts are better and they're virologically suppressed? Some of the pros for vaccinating early include earlier protection against some more common infections, for instance, influenza, which is seasonal. There would be more of an argument for vaccinating early rather than delaying several months or a year. And then the issue for maybe doing it later, a factor that may push you towards waiting is the decreased likelihood of response if your T cell counts are low or you're not immunologically or virologically suppressed. So some of those issues have to be considered. And then, of course, the issue of live vaccines and immunocompromising conditions. So how do we approach using live vaccines in patients with HIV? So I'll start by going through some of the common vaccines we use in practice. So hepatitis A, fortunately we've got Dr. Scott here today to elaborate more if necessary, but we've got, of course, hepatitis A vaccination is now a universal vaccination. So most of us in this room did not get hepatitis A vaccination when we were born because this is a relatively recent addition to childhood immunizations. And so at age 1, all children are getting vaccinated. But in adults, it's not routinely recommended for all adults, except if you have certain risk factors. And same in the HIV-infected population. So most of our patients who are HIV positive will fit into one of these categories, which is why we go ahead and vaccinate everybody with HIV for hepatitis A if they're non-immune. However, when you look at the formal guidance from ACIP, the Advisory Committee on Immunization Practices, or even the OI prevention guidelines, which are put out by the CDC and HIVMA, are that we should be vaccinating non-immune HIV-infected adults who are MSM, because there's a higher incidence of hepatitis A, which can be fecally orally transmitted in MSM, injection drug users, people with chronic liver disease, and of course if you're traveling to endemic areas. There's also another one that's relatively new. If you're adopting children from endemic countries, you should also be vaccinated. So again, most of the patients that we see in the Northwest, their main risk factor for HIV is MSM, and so we end up going ahead and immunizing everybody with HIV essentially for hepatitis A if they're non-immune. Hepatitis B is also, vaccination is also now a universal vaccination at birth. Most children, when they are born in the hospital, will get their first dose of vaccine. Of course, that's only come about in the past few decades, so adults haven't been immunized for it in general. But when it comes to HIV, it's recommended for all non-immune HIV-infected adults. Again, the same risk factors for transmission of hepatitis B are risk factors for HIV, so that's one of the rationale. The efficacy of that vaccine really varies, so anywhere from 18 to 72% in the literature. There have been some studies, one from here by Dr. Kim, Nina Kim, and Bob Harrington, who's one of the speakers here for ECHO, that virologic suppression is associated with better response, and higher CD4 counts are, of course, associated with better response. So that, again, is a consideration for timing. There are some discrepancies that I'll point out in terms of vaccination guidelines, particularly for hepatitis B, is the one that's really obvious in terms of the differences between the ACIP recommendations and the OI prevention guidelines. So most of us use the ACIP recommendations when we're talking about our general population when it comes to immunization practices. It is sort of our go-to guidance for immunization practices. However, we as HIV providers use the OI prevention guidelines that are put out every year to 2 years to guide us as well. So the ACIP recommends for HIV-infected individuals or other immunocompromising conditions a 40 microgram dose, which is actually a double dose of vaccine, either for 3 doses or 4 doses. The OI prevention guidelines actually just recommend standard dosing times 3 doses. So the OI prevention guidelines are coming out soon. They're soon to be published, and I can tell you that they have not revised their recommendations to use the standard dosing. They will continue to be recommending the standard dosing, even though ACIP recommends the double dose. The reason that's important is because the ACIP had been recommending this 40 microgram dose based on data in hemodialysis patients who are relatively immunocompromised, where there's good data that using the higher dose leads to better degree of protection. We didn't have that really robust data in HIV-infected individuals until last year when there was a publication in JAMA that looked at that showed that using a higher dose times 4 doses led to significantly higher rates of serologic response. So on the order of 82% compared to 65% with the standard dosing regimen. So
what do you do in Madison Clinic? You do the 40?
We do the 20.
Okay.
The standard
times 4.
Times 3.
Times 3. Okay.
Yeah. So, and I'll talk about the topic of revaccination sort of later on and as it pertains to this. Special consideration about hepatitis B. So I mentioned that for all non-immune HIV-infected adults, we should be given the vaccine. However, we do have not an insignificant number of individuals in our clinic, at least, and I assume that you all do too, that have isolated hepatitis B core antibody positivity. So what do we do with these individuals? So isolated core could reflect occult Hep B infection, it could reflect a false positive, or it could reflect more likely a waning surface antibody response. And so how do we tease this out? And so what we're actually doing in our clinic is we're going ahead and giving a booster vaccine dose and rechecking the antibody level in a month or 2 after the booster dose to see if they have a memory response. And this is just reflective of a waning antibody response. And that has generally been what's recommended with the isolated core antibody. A small percentage of people it will reflect active disease, meaning that they can have a positive hepatitis B DNA. Again, this is a very small percentage, and you can look by looking at the ALT and some other markers if they do have evidence of active disease. So moving on, pneumococcal disease. So this is obviously a common illness, and we have a vaccine that's not necessarily efficacious in the general population for preventing pneumonia, but preventing more invasive disease, and meningitis is why we vaccinate. So HIV-positive patients have a higher risk for invasive pneumococcal disease. We know that. The efficacy of the vaccine, though, for patients with low CD4 counts is really unknown. We don't, unlike with hepatitis B, we don't really have a good marker of a seroprotection, which is why the efficacy is really unknown. But the recommendations by ACIP and by the OI prevention guidelines is to go ahead and vaccinate when someone comes into care, even if their CD4 counts are low, because this is such a common disease. And then go ahead and consider revaccinating once they are above 200, so that you know that they have a better degree of protection. The guidelines also recommended giving a booster at 5 years after the initial vaccine, but at only times 1. And then again, once you're over 65 years old. They don't recommend repeating every 5 years, which I know some people do in their practice, but this is not a current recommendation. Influenza. So we know that influenza can be more severe in patients with HIV. There are no increased adverse effects with the inactivated vaccine. Again, this is not a live vaccine. Efficacy ranges from 27 to 78%, so again, widely variable, but you could argue that in the general population, the efficacy varies as well, depending on the antigenic match of the vaccine. The live vaccine is not currently recommended. However, there is data in HIV-infected individuals that show that it is likely safe. It's just not currently recommended. And we know that it is likely safe in that household members of people who are HIV infected have received the live vaccine, and it hasn't led to any adverse effects or acquisition of the vaccine-related illness. So Tdap, and as we know that there is a little epidemic going on in our area, in our state, of whooping cough. So this is definitely relevant, and Washington State is the second least vaccinated state, I think, in the country, second to Vermont when it comes to childhood vaccination. So this is very relevant. There's no specific recommendations for individuals with HIV, and this is, again, because this is not a live vaccine. And so there's not really a timing recommendation. Tdap should replace a single dose of tetanus, diphtheria, regardless of the interval since the last tetanus. And now there's no upper age limit as well. It used to be previously if you're only if you're under 65, and now there's no upper age limit given the number of cases we're seeing. And it'll likely be that Tdap will replace the every 10-year tetanus, but so far that guidance hasn't come out yet. But we'll likely see that in the next iteration of the guidelines. HPV. So this is something that comes up when we see younger patients, and we wish that we could do it for more patients, but there's not really any guidance. So for those of you that are seeing patients who are adolescents or in their 20s, this is more relevant. It's not a live vaccine, so it's safe in HIV and other immunocompromising conditions. There are 2 types of vaccines available. There's a bivalent and a quadrivalent, and the biggest difference is that the bivalent covers the serotypes that are associated with cancer, whereas the quadrivalent covers those that are most commonly associated with warts and with cancer. For females, either vaccine is recommended for women with or without HIV, and the age range is from 11 to 26. In men, this wasn't previously approved in men or recommended in men, and this a significant change in the past year. And so far, there's only recommendations for the quadrivalent vaccine in men at age 11 to 26. And there is a statement that 11 to 21 is preferred, and I think basically because the cost of effectiveness of the vaccine is much better when you're giving it earlier. You want to try to give this vaccine prior to sexual debut to get the most benefit from the vaccine. But just because they've had genital warts or other manifestations of HPV, it doesn't preclude giving this vaccine if you are within this age group, because there still may be a benefit because you may not have protection against these other serotypes that are contained in the vaccine. There's no recommendations currently for HIV-positive individuals greater than 26 years old. However, there has been some There have been a few studies looking at this vaccine in older HIV-infected men. There was one study that was published in 2010 that looked at men with who received the vaccine, and they were a median age of 44. And it showed that it did confer some protection based on antibody levels. However, that's not really a good marker of protection from this vaccine, however. So jury's still out about whether we should vaccinate earlier or later individuals, but there's no recommendations for that at this time. Live vaccines, just in general, live vaccines are not recommended in severely immunocompromised individuals. There's not a lot of data in some of these instances. We do have data for the varicella vaccine in children, nothing in adults, so not studied in children above 13 years of age or individuals above 13 years of age, and this is extrapolated. But based on that data, it's safe to give to individuals with a CD4 count greater than 200. So if you lack evidence of immunity and your CD4 count is greater than 200, it's okay to get the varicella vaccine, and it is recommended. The zoster vaccine is not currently recommended, and it's contraindicated in individuals with CD4 counts less than 200. There's no recommendation for individuals with HIV greater than 200, but there is a study that was presented at CROI this year that showed that it was safe and immunogenic in adults with CD4 counts greater than 200 who are virologically suppressed. So we may be seeing some change in guidance based on this study. The MMR vaccine, again, a live vaccine that is not recommended in HIV-infected individuals with CD4 counts less than 200. A vaccine that is not contraindicated is the MMRV. The vaccine the MMR that contains also varicella is not recommended with any CD4 count threshold in people with HIV. So special considerations, the vaccine non-response issue. So what is a response? In the case of Hep B, as I mentioned, we know that there's a protective titer threshold that's associated with protection from the virus. So there's a serologic marker that confers protection. Most vaccines, we don't have this data. Like in hepatitis A, we don't have a correlate of immunity. So when we talk about non-response, we don't necessarily have a good marker, except with the situation of hepatitis B. We do have a good marker, so we know that a seroprotective level is 10 international units. So which is why it's the only vaccine where we actually recommend looking at a titer within 1 to 2 months after completion of doses. And if you have a subpar response or a null response, so less than 10, then you would consider repeating the series when viral load is suppressed. And there are some ways to do that, and there's not a clear consensus. The OI prevention guidelines say that you could repeat a standard dose or you could repeat a double dose, and I've included that reference that I alluded to earlier and the data from that study. So there are some ways that you can deal with this. I just reviewed a manuscript that showed that in African patients, just giving a fourth dose of the standard dose actually led to a 94% response rate. So maybe it's just an additional dose that's needed for individuals, but this is something worth checking in your patients. And here is the ACIP 2012 adult schedule, which kind of goes through, and you can see there in the column HIV-infected individuals with CD4 count. It's less than 200 and 200, and this is a really good go-to reference for what's contraindicated and what's recommended for your patients. Here are the links to the resources.